Hello, I am Marwan Aburas. This presentation focuses on ADI-3 in the 10 ADI diagnostic interest. It's on the root canal proper, okay? Or what we clinically refer to in practice, the main canal, the central canal. By the end of this presentation, you will have an evidence-based understanding of the whole anatomy and radiographic features of the root canal proper, as well as a clearer perspective on what we often refer to as the lateral canals, the accessory canals, the furcal canals. One of the most common misconceptions in endodontic diagnosis is the misleading MB2 orifices. They call them canals. In reality, many of these structures, though visible on radiograph under magnification, they are not functional at all as a canal. According to the literature, 70 to 80% there are accessory canals. They are merely openings, extensions from the pulp chamber or the canal wall, and end blindly in dentin or cementum. They don't go to the PTL. They are the remnants of vascular channels, blood vessels, connective tissue, pathways during the tooth development stages. And to instrument these is unnecessary. It can also be risky and may complicate the endodontic treatment, compromise the tooth. To clarify, what we often call the root canal is an interconnected structure. They call it system, okay? So in my opinion, the primary system is the canal, which we address through endodontic treatment, instrumentation, and obturation. But the other one is called accessory system, include fins, fissure, isthmuses, okay? And this we should manage by chemical, not instrumentation. This presentation is organized in 4 key objectives, okay? So first, we define the difference between primary and secondary root canal anatomy and how each must be approached clinically in treatment. Second, we examine radiographic images of the root canal proper, both in untreated and endodontically treated teeth. Very interested. We will explore how the root canal image changes due to caries, calcification, internal, external resorption, and other pathologies for both treated and untreated teeth. We will go through underfill, overfill, ledging, broken instruments, all of that, post-perforations. The third objective, we will focus on the diameter of the root canal at the apical third. Very important, the last 3 to 5 millimeters. This area is especially vulnerable to resorption, perforations, foramen transportation, okay? And your clinical understanding of this area in terms of dimension is very important in instrumentation and obturation. Fourth and finally, we will review the concepts of danger zone, okay, and safety zone within the root canal, especially in the narrow or curved canals. This anatomical landmark, okay, formed the basis of my anti-curvature filing technique, which we published 1980s. We'll examine the clinical situation, method, and what happened when you violate the anti-curvature concept. We'll show radiographs that support these objectives and clinical photographs that being, supporting each concept. By understanding the actual anatomy of the root canal proper and its distinction from the accessory structures, okay, you will be equipped to perform better endodontics, biologically sound endodontic treatment, okay? That's very important, the differentiation between the primary system and the accessory system. Let's begin.